with cancer. This is very brief. This is not everything you need to know about cancer. If you go work on a cancer unit, you will get a 6-week course on cancer. So this is basic information on it, and giving you information to safely take care of patients that are getting chemotherapy, radiation, and possibly some other treatments. But you just need to know a little bit of background to cancer, because the background helps you understand what you're telling and teaching your patient. So cancer is technically an autoimmune disease. Technically. Our body cells normally detect and get rid of miswritten, where our cells replicate constantly. We make new ones, we kill off old ones. As old cells die and don't work, we kill them off, we get rid of them. It's a constant factory of replication. Anytime a cell replicates, it has a chance to replicate badly. I don't know if you guys took biology or remember biology, but if your cells replicate, they have a chance to mess up. If they mess up, they're supposed to recognize that they're dysfunctional, or the white blood cells are supposed to recognize that they're dysfunctional and kill them because they're dysfunctional. They don't have a purpose. They need to be removed. This is not a lovely society all in us. This is if you don't have a purpose, you're out society. So if an unrepairable cell is supposed to kill itself, and I love this word, it's my favorite word in the world, apoptosis, because they have to kill themselves. Pop. So basically a cancerous cell is a cell that didn't get caught. It's replicated. It's either useless or dysfunctional, but it didn't get caught and killed, and it's replicating itself. So now we have multiple dysfunctional or messed up cells in our body. So they never self-destructed and they're multiplying. So it is technically an autoimmune disease because we didn't kill it when we were supposed to, or it didn't destroy, or something didn't happen, and it's going out of control. So cancer is a normal body cell that is not doing its normal thing. It's basically a useless freeloader that's using our body. It's like a virus, or it's like a bacteria. It's a freeloader. It's a cell that has no purpose, that is replicating. Yes?
If you already have an autoimmune disease, are you more likely to get cancer?
Good question. It depends on your autoimmune disease, not necessarily, because a lot of these autoimmune diseases are a flare-up regarding, like, oh, I recognize something. They recognize something as normal and killing it off. Not necessarily, but what does give you a higher risk of cancer is, guess what? Shutting down your immune system. So if we shut down our immune system very, very frequently with corticosteroids, immunosuppressants, nonsteroidals, then if we shut down our immune system a lot, well, can this apoptosis happen very well? Not 100% efficiently. So there are a lot of things that increase your risk of cancer. There are studies that will link anything to your risk of cancer. Okay, a study, if you're in your BSN program, you can find out that you can get a study to say whatever you want. We can find a study that says wearing glasses increases your risk of cancer. Because if they study enough people, some of those people have glasses and some of those people have cancer, they will link together. You can find a study that links anything. Not just because a study was done doesn't mean it's right. Another passion of mine. But I could publish a study tomorrow and have data that will back up that people with glasses are at higher risk of cancer. I could find that data if I wanted to. I know, really, right? But so not every study, don't take everything with a grain of salt. You got to learn how to be good readers of data later on. That's what BSN is for. It teaches you a lot more of that stuff. But the more often a cell replicates or has to repair itself, the more risk for mutations there are. So cells that replicate quickly are more at risk for becoming cancerous, and cells that have to repair themselves very frequently. So if you have a disease process that messes with your cells all the time, like alcoholism, you're constantly damaging liver cells, and the liver's constantly repairing itself. It has that ability, but the more it has to repair itself, the more chance there's a mess up in the repair process, and that there's a mess up. So whenever you have frequent infections of a certain area, you're at more risk for cancers in that area, because basically every time it replicates wrong. Lung cancer is caused by smoking, because you're basically taking toxins into your lungs nonstop And those lung tissues are constantly having to regenerate, kill off the old bad ones that got tarred up, and put in new clean ones. The more often we have to do that, the more risk that something replicates wrongly and something grows. So the more you expose yourself to skin, well, you get burned, and the body has to remove all those burned little things and put in fresh ones. The more often that has to happen, the more risks you have for a mess up. So anyway, you don't have to memorize this list. Just know that if you have a problem that constantly irritates a certain organ, you're at risk for cancers in that organ. There are two words, benign and malignant. Mostly this is vocabulary. Your interventions and the things that you're going to need to know are going to be when we get chemotherapy and when you get treatments for this. We can't prevent cancer other than screening and keeping them out of their, knowing about their risk factors. But a lot of this is vocabulary. So benign means that, yes, there are bad cells. They are replicating, but they grow locally and they're not free floating. They're state attached. So let's say we have a melanoma, like something on our skin. We've got a bad skin cell. It didn't get and it's starting to replicate. What are we going to end up with? The skin cell is replicating and growing and it's useless. You're going to get a big mole. It can be benign. A lot of them are. Benign it grows out of control and the body finally is like stops, it kills them off and they stop growing or whatever. Some moles are just benign. They don't go anywhere. Some of them continue to grow. Like they just get out of control and you end up with a big, weird, irregular thing, or you get a tumor. A tumor is just something big and grown out of control. They can damage local tissues due to size, but the body will kind of encapsulate them and be like, fine, you exist, you live, but just don't grow anymore, okay? Just stop it. And I'm not going to get rid of you. I'm just don't do any more. But benign ones just kind of live. They live, and we can remove them, we can take them out, we can let them stay, we can do whatever, but they're not going to go anywhere. Malignant ones have the ability to spread and invade other tissues. So I have and I like this little picture over here. If one of the replication errors is losing the molecule that keeps it attached to where it's supposed to be, then that cell becomes like a little free floater. Well, it can go anywhere. Once that cell has gotten to the point where it gets disattached, it goes anywhere. So this is like a cell. So here's benign. It's just growing. They're replicating. There's a little bad cell there, and it's replicating, and it's getting bigger. Once one of those cells then replicates and loses its attachment gene, or whatever it does, whatever little magic it has to attach it, once that happens, it has become malignant. Because now it can move. Malignant means it can move. And then it moves, and it ends up getting absorbed into the bloodstream somewhere. And then you find out, so this is a piece of skin tissue, a deformed piece of skin tissue, a little deformed piece of skin cell. And it shows up in the liver. You don't get epithelial cells in the liver. There's no epithelium in the liver. There should only be liver cells in the liver. But now we've got a little cell. It's just a useless piece of crud. It doesn't do anything. It's supposed to produce oil or hair or whatever it does in the epithelium, but it's not doing what it's supposed to be doing. But now it's sitting in the liver, and it's replicating, and it's creating a big ball of epithelial cells in the liver. And it's not supposed to be there. So what it does is it starts taking over liver space that healthy cells should live in, and it starts taking over space. The problem with these cancers is they take over space that they're not supposed to take over. And then they cause problems because they're taking over that space. And then the healthy cells can't do what they're supposed to do. So that's metastasis is just becoming metastatic means that the cell now can move. And metastasis means that there is a cell that doesn't belong in another organ. Okay? So you can have, a metastasis from a lung cancer. Lung cancers, so there's a tumor in the lung. There's a giant little, and it starts out, it's not malignant, but it's a wrong cell that shouldn't be there, and it's growing out of control. But then during its replication, its tumor replication process, it loses its little gene to keep it attached in the lung. Now that lung tissue is running around in the bloodstream, and it ends up in the brain. We have lung tissue in the brain. Well, and not lung tissue, it's not breathing, but lung tissue produces mucus. It does whatever that little piece of lung tissue was supposed to do. That lung tissue produced mucus, whatever. It's a little piece of lung tissue, but it wasn't doing what it's supposed to be doing anyway. It's a messed up little cell. So it's a piece of lung tissue in the brain growing and growing and growing in the brain. Well, one, it doesn't have any function. It doesn't even do the function that it was supposed to do in the first place. But now it's taking up brain space. And it's growing bigger and bigger in the brain. It's compressing healthy brain tissue and not allowing brain tissue to function. So that's how they kind of define and look at it, is when they do those biopsies, they go in there and they take a piece of the tissue and they're like, where did it come from? Where is it? Is it supposed to be where it's supposed to be? And that's how they end up deciding whether it has metastasized or not. So there's just different types of cancer. This is all vocabulary. Carcinomas are epithelial tissues, so skin tissues. And actually, this is skin and organ. So any organ cancers are carcinomas. So that it's from where we originate from, like as we go from babies to whatever. Anyway, skin tissue turns into organ tissue. Sarcomas are in connective tissue. Myomas are in the bone marrow cells. Leukemia are specific to bone marrow. So myelomas bone marrows are like factories for white blood cells, red blood cells, platelets, plasma. There's all kinds of stuff created in our bone marrow. So if we have an issue in our bone marrow, we have issues with creation of that stuff. You don't have to memorize this list. It just helps you understand. And then there's naming. So let's say we have a liver. So hepato is the word for liver. If you have a hepatocancer, what's it going to be called? It's going to be called a hepatocarcinoma because it's an organ. If you have a tumor in your fatty cells, is fatty cells an organ? Or what is fatty cells? They're connective tissue, so it's a liposarcoma. You don't have to put these together. You're not diagnosing, but it helps. It's interesting. I like it. That just kind of helps you tell where it is. So there's that. You will probably need to know tumor, node, and metastasis. Okay, this is just staging. Do you stage cancers? No, you do not. Not unless you're an oncologist, which if you are, please let me know if you're an oncologist. But tumor, node, and metastasis, I need you to know that is the way that they stage cancers. The reason you need to know this is that you can help a patient understand their diagnosis when they get, you're a TNM, you're a T0N1M0. Well, okay, so that probably wouldn't work. All right, let's say T1N1M0. So T1 is just the size of the tumor, the original tumor that they're finding. They don't know if it's a metastatic tumor or anything yet. They just know they found a tumor in your lung. You have a tumor in your lung, it's T1N1M0. So it's a tiny tumor because you can see the T4s are big ones and T1s are itty bitty ones. So it's a tiny tumor. Is it in the lymph nodes? Has it spread? Is it starting to move? So do you think that anything N1, N2, N3, are they considered metastatic? We don't know yet because in the lymph nodes means that it has been removed from that area. So it could be just part of the cleanup process. It could be that once it's in the lymph nodes, it's easy to start circulating. So they can move. They're on the move. So they're not in the lymph nodes means that tumor is stuck in one spot. It hasn't moved yet. Very easy to treat. Once it's on the move, we have to start looking around the body to see if it's gone anywhere. But anyway, N1 means that it's in the local lymph nodes nearby, so it could be just part of the cleanup process. N3 means that it has started spreading to multiple lymph nodes that are far away, meaning that it is on the move. So N1 is not nearly as bad. So if you have a patient that's T1, N1, M0, are they early or late stages? Pretty early. We've caught it pretty early. So I just need you to be comfortable and familiar that T and M is just a way to classify them and kind of let them know where it is. If you have a T4, N0, M0, is that bad? It's a big old tumor, but it hasn't gone anywhere. So if you have a T1N3M1, that one's on the move. It's a small tumor, but it's already on the move. So it's probably pretty rapid, pretty aggressive. So you could kind of get an idea of what they're dealing with if you see that. It's just to help you understand so that they understand. I don't expect you to be oncology specialists by the end of this. This is just kind of another way to stage things. So that T4 N0 M0 hasn't gone anywhere. It's a big tumor, but hasn't gone anywhere. What do you think stage it would be? It's either a 0 or a 1. It's big, but it hadn't gone anywhere yet. Stage 1 to stage 2 means it's moving into those lymph nodes. It may be getting cleaned up. It may be moving around, but it's starting to move around. Stage 4 means it's already gone somewhere else. We found it somewhere else. We found lung tissue in your liver. We found lung tissue in your brain. We found it's metastasized. Stage 4 means it's already it's gone. It's already traveling. And once it's traveling, it's much harder to get a hold of. So we want to catch them before they start traveling, before they mutate to the point where they travel, and before they travel around. So here's our treatment, and so the treatment's going to depend on the stage. Okay? Not everything, there's no certain, schedule for it or whatever. That's what an oncologist is for. What I'm going to teach you is what we're going to see with the patient. So we're just assuming that they're getting the proper treatment from their oncologist, okay? If they're on chemotherapy, then they're on chemotherapy. We're going to just deal with the side effects of it. If they're getting radiation, they're getting radiation. We're just going to deal with the side effects of it. If they're getting chemotherapy for something autoimmune, sometimes these chemotherapy drugs are used for things other than cancer because we are trying to control something. So sometimes you'll see them on chemotherapy drugs for other things as well. And we'll talk about, you'll see them pop up as therapy treatments. So I think you were mentioning, for rheumatoid arthritis, a lot of these autoimmune diseases that are out of control and we're trying to get them under control, they put them on massive immunosuppressants, and some of them are considered chemotherapy. But chemotherapy basically it's a toxin. We're giving you a poison, saying, here, have this poison, enjoy. But what it's going to do is it's going to kill the cancer cells, but it's also going to kill anything that is rapidly replicating. So it's a toxin that's going to go in there and kill the DNA of anything reproducing. Anything reproducing. So while you get chemotherapy, anything that rapidly reproduces is going to get affected by this thing. Hopefully, it will kill off those rapidly replicating useless ones. They disappear, and then everything else heals because they're supposed to be. But right now, the side effects are due to the inability of healthy cells to reproduce because we're killing off reproduction. We're saying no reproduction is happening in your body. No cell reproduction. We're killing it all. It's broad. There are different ways. Sometimes it can be aimed at curing things. Sometimes it's aimed to shrink them. Sometimes it's just to keep symptoms under control in the end stages. But basically, it keeps tumors from getting larger, but it also kills off healthy cells. So what we see, you give someone a toxin, they're not going to stay healthy. Okay, we give someone chemotherapy, they're going to have side effects. These are things that we expect to happen with chemotherapy. You need to know the difference between what's expected and what's not expected. But we expect fatigue. The body's tired. Okay, it's doing a lot of work, so it's going to be tired out. The GI symptoms are due to GI tract. They only live 2 to 3 days. It's an acidic environment. These cells replicate nonstop. You're constantly redoing the lining of your GI tract. So the GI system gets hit hard by chemotherapy because these cells are rapidly replicating. That's just what they do. They replicate every 3 days. So if we interrupt that, you're going to have problems with your GI tract. So you're going to get sores because those cells can't reproduce to fill in. Sores come from this is an acidic environment. It eats away. And unless we're reproducing cells to fill in the things that get eaten away by the acid in our mouth and our GI system, you're going to get sores. So they get a lot of sores. Nausea, vomiting, because you're giving it a toxin. It's trying to get rid of it. It's like, what are you doing? Why are you taking poison? Blech. So nausea, vomiting, diarrhea, same thing. It's like it's going to try and get rid of this toxin any way it can. But you do damage your GI lining. So you have damage to your oral mucosa, damage to your GI system. You could appetite loss. You may have some problems, which that's not expected. We expect to see the GI system to have some problems. Most of them are sores and nausea, vomiting, and diarrhea. Blood disorders. Blood cells reproduce very frequently as well. White blood cells reproduce every 2 weeks, 2 to 3 weeks. Platelets reproduce every week. So that blood cells are being replicated in your bone marrow all the time. We're constantly making new ones. So we give them chemotherapy. Guess what's not going to happen? You don't make any new blood cells. So you're going to have a deficiency of blood cells. Nerve damage. It's a toxin. It's a toxin to your nerves. It's toxic to your nerves. You end up having headaches, achy muscles, weakness, numbness, tingling, burning. Nerve damage. Nerves don't repair very quickly. So if we damage the nerves because of the toxins, they may or may not repair. But that is normal. Changes in thinking and memory. Well, we're killing off. We're doing toxins to nerves, so you're not going to think quite straight. Hair loss. Hair follicles divide every 23 to 72 hours. So every day we're making new hair. And so chemotherapy is going to cut that off. And the hair will fall out. So basically you keep your old hair for a while, but no new hair is growing to replace it. It will fall out and there's nothing to replace it. So chemotherapy, that's why it causes hair loss, because that's a rapidly replicating cell. So GI, hair, blood are our most common rapidly replicating healthy cells. That's what chemotherapy affects. What we are going to worry about, and this is what I really want you to think about with oncology, these are the things that we see that mean the chemotherapy is not being tolerated and needs to probably be stopped, or you need to monitor them much more closely, okay? So if you see any of these things, you would want to notify a physician. Do you notify the physician that they're having nausea and vomiting? It's expected. There's a big difference, and that's one of the things we have to learn is when do we call for our help, or when do we call our physician? If it is expected, don't call a physician. Okay? Hey, my patient's, having nausea, vomiting with chemo. They're going to be like, yeah, I know, thanks. Thank you for the update. Click. You want to let them know if things are going wrong, and this is signs that things are going wrong. Severe hypercalcemia. So for some reason, this toxin has gotten into the bone. The bones are breaking down and releasing too much calcium into the bloodstream. You will find out in your fluid and electrolyte lecture that high calcium can cause these problems. So if their calcium levels going up, or you can't wake up your patient that's on chemotherapy, what would you ask them to look for? You have a patient on chemotherapy, you go in, you're like, hey, wake up. And they're like, what do you want to go to chart and look for?
Labs.
You're going to look at your labs, and hey, if your calcium level is up to 24, I better go. So that's one of the things to look for. Severe thrombocytopenia, that means that your platelets are super low. That can happen because platelets replicate every week, and if we're giving them chemotherapy, strong chemotherapy can knock out your platelet production. What are your platelets involved in? Clotting. So if you don't have platelets, what are you not going to do? Clot. You'll be bleeding. So a lot of unexplained bruising, bruises all over the place, or active bleeding. You'll want to call on that. That's not normal. We don't want that. We don't want our patient bleeding out because they're on chemotherapy. Tumor lysis syndrome is basically stuff being released from tumor cells that, as they're being killed, they lyse open and release a bunch of crap into the body and basically cause renal failure. So if your kidney numbers start going up or their urine output starts dropping while they're on chemotherapy, that's something you need to notify. So just make notes of the things that you need to notify if they're on chemotherapy and know those. If you have a fever while you're on chemotherapy, that is always something you need to notify. They are not replicating white blood cells, so as your white blood cells are used up, they don't get replaced, right? So normally we circulate them around unless we use them, and then we have to start replicating them more. That's why your white blood cell count goes up during an infection. We're making more to combat an infection. So say you get a cold while you're on chemotherapy. So the white blood cells that exist go and kill off things, but they're not replaced. So what happens to your white blood cell count? It drops out. Neutrophils are baby white blood cells, so that's just meaning, so you don't have any babies to replace the adults. The adults are dying in the field, and there's no babies growing up to replace them. So if you have neutropenia, meaning low baby white blood cells, low white blood cell count, and you get a fever, what does that mean?
Infection.
You have a rampant infection. You have a really bad infection because you really can't really mount a fever very well when you're on chemotherapy. So if your body has gone through the work to mount a fever, it's in trouble. It's in trouble. So even a low-grade fever is a problem when you're on chemotherapy. You will want to report any kind of fever during chemotherapy because it could be a sign that there's a bigger problem. Something that you wouldn't bat an eyelid with in a normal patient. A fever in any kind of chemotherapy patient is a problem. If they start having, if we start having nerve damage, paraplegia, I'm going to probably call. Anything that's new problems there, that's one of the oncologic emergencies. Severe constipation, I haven't gone to the bathroom in a day, but like I haven't gone to the bathroom in a week. What can that do if you have severe constipation? That's a bowel obstruction, basically. We got to get to the root of what's going on there because if that bowel expands to that point, your bowel could burst, and then that's a big problem. So severe constipation is something you would want to report, and severe constipation means more than 3 to 5 days. I mean, some people don't poop for 3 days in a row. Some people don't poop for 5 days. What's normal for the patient? Do you usually have a daily bowel movement and you haven't had one in a week? Ooh, I'm going to call. Do you usually go 3 days and... now it's 7. Okay, that's a problem. What are you going to listen to? Now, I'd listen to the bowel sounds and be like, is there something going on down there? But yeah, we would want to notify that because there's something going on there. Definitely anytime you get chemotherapy, it is a toxin. We don't want it in our tissues. It will kill everything in our tissues. So if it's going into an IV, you're definitely going to keep an eye out. Anytime that chemotherapy gets out of the IV and into tissues, that's going to be a problem you'll have to call. So definitely know your oncologic emergencies versus your expected side effects. I'm going to give you, there's a test question on that. So chemotherapy, these are our interventions. So we know our worst case with chemotherapy, okay? If we're doing our little SOAPy chart, you know your expected side effects. When you have chemotherapy, you expect those side effects that we looked at when we said expected side effects. Put those in there. Your worst case scenario, your priorities, your things that you don't want are any of these, okay? We don't want any of those. Your interventions are basically to keep the patient comfortable around those expected side effects, okay? We know the GI system's going to be messed up. We're going to give them antiemetics. We're going to give them nausea, vomiting. There's a whole bunch of interactions for that, for sores, fatigue, just let them sleep. I mean, basically, it's common sense, right? If you had all these things, that's what you would want. So you can read through that. If you end up with any of those things that we don't like, the low white blood cells, the low neutrophils, the thrombocytopenia, first you're going to let them know. But what's the problems we're going to have with low white blood cells? It's in red.
Infection.
High infection risk, okay? So you are definitely going to watch for the temperature, okay? Watch for fever. Fever in a neutropenic patient is always an emergency. Watch your fever, watch your vital signs, blah, blah, blah. These are actually, you'll see these in the hospital, neutropenic precautions. Those are standard hospital precautions. They're not just nursing interventions, it's an actual level of precautions we can give to a patient. They have low neutrophil levels, low white blood cells, they'll be on neutropenic precautions. Meaning they don't get flowers in their room. You think, oh, why not? Well, there's stuff in the dirt. There's like all kinds of bugs and bacteria and stuff and flowers and dirt, and so we don't want any of that in the room because they're a high infection risk. So those neutropenic precautions would go with anyone with an infection risk, but especially and then there's pulmonary toilet, there's that word. Coughing, deep breathing, why do we do that? Why do we want to? You want to keep your airway clear. You don't want bacteria and crap growing in the lungs because they're at a high infection risk. The body won't be able to take care of it. It will develop into a pneumonia pretty quickly. Thrombocytopenic precautions are just low platelets. They are a high risk for bleeding. So there's some interventions. I put those there because you find a lot of cancer chemotherapy patients on those precautions. Once you've notified the physician, hey, my white blood cell count, they might just be like, okay, but you need to let them know that that's going on, because they might need to adjust the doses of the meds, or maybe they're not tolerating the med, or maybe, but then they end up on these precautions as well. And those are things that you're going to watch for. Radiation is another form of treatment, sometimes with chemotherapy, sometimes by itself, sometimes, but there's different kinds, and then I'm going to tell you the things that we're looking for. There's the regular, you're going to sit under a radiation machine, you're going to get something beamed at you. That's outpatient. They can go in every day for a dose of radiation. Again, this is a toxin, straight to the tumor, right? We're going to irradiate the tumor, hopefully kill those rapidly dividing cells, but it's going to kill rapidly dividing cells around it. Brachytherapy, if you see that word, is where they put radiation pellets into your body somewhere near the tumor and let them irradiate the tumor from inside. So they're called seeds or mesh. Like sometimes with breast cancer, they'll put like little radioactive pellets near the tumor and let it do its thing, let it try to kill the tumor right there. And we'll talk about some precautions with that. And then systemic radiation therapy is really where you drink something radioactive, like radioactive iodine for thyroid cancer, and it goes and targets a tumor cell. So again, what can happen with these? Radiation skin changes. This happens with the external beam therapy. Okay, this probably isn't going to happen with the little seeds that are inside your body, but this is for if you're beaming radiation at something. Has anybody had experience with this, with patients or family members that have had radiation? Yeah. My mom had breast cancer and had external radiation and got the wet desquamatization. So there's two different kinds. So basically, we are killing skin cells. We are beaming radiation through the skin cells to the tumor. It is going to kill off some replicating skin cells, just like if you got a sunburn. This is no different in care than a bad sunburn. Okay, so if you've taken care of a sunburn or a bad sunburn, you know how to take care of these skin radiation side effects. If it's dry, if it's not open, meaning that it's not oozing, this is a first-degree sunburn, right? You've taken care of those. You put aloe on them. You make sure that they, you don't put lotions on that irritate them. You don't put skin over it that'll rub it. Anything you would do for a sunburn is what you would do for dry desquamatization. That is basically a sunburn from radiation therapy. Wet desquamatization is just basically a deeper sunburn. So if you had a second-degree sunburn or a blister that popped, that's what this is going to look like. So if you had a bad blistering sunburn, are you going to put lotion on it? No, don't put lotion on blistering things. Keep it clean, saline water. Don't let them put harsh soaps on things like this. I mean, you wouldn't do that if you got sunburn. You're not going to go in there and lather up with your lavender scrub or whatever. I mean, a lot of this is common sense, but if it's wet desquamatization, it's like a sunburn with blisters is what it is. Keep it covered. Don't go out and sunbathe with it. Keep it covered from the temperature extremes. It's going to hurt. Common sense. I'll let you read through that. But most radiation side effects are skin-based for external beam. Let me see if I have a slide. These are some things. So if you have head and neck cancer, it's all going to be depending on wherever a beam is located. If you are trying to irradiate something in the brain, if you got radiation going there, you're going to end up with, irritation around there. It might affect your eyesight if you're doing something. So, if you're doing radiation to these areas, you may see problems with that. It's just you're beaming radiation to something. It's going to hurt stuff. So you can kind of read through this. I think a lot of this is kind of common sense. I don't think, I didn't put a slide. For the brachytherapy, what do you think if you have seeds implanted? So let's say the patient has prostate cancer, and they decide to they do this a lot they put it looks like a little tampon full of seeds, in that area. They implant it, and they let it radiate locally to the area. if you're putting radiation into your body, what do you think your precautions are? And I should have a slide for this. You can look it up or make a note to look up chemotherapy precautions or radiation precautions for the patient. This is something I need to add a slide. I thought I had added this slide. How did I not have chemotherapy precautions? Okay, what do we do? So the patient's getting chemotherapy or radiation. It works for both ways. They're getting a toxin in their body. Do we want to spread this toxin around to other people? So what are our precautions with chemotherapy and radiation? Yeah, they shouldn't be around pregnant women, definitely with the radiation therapy. So with the radiation therapy, you are a walking radiation source. They are supposed to keep a 3-foot radius around them clear. You're a walking radiation source, even though it's just some radiation sitting, near your prostate or there. Sometimes they do it for lung cancer tumors or whatever. But you're not supposed to hold your children or cuddle your children or keep them close on your lap. You could certainly interact, but you're not supposed to have a lot of close contact because you are radioactive. What happens to your outputs, like your pee and
You
your...
have to flush 3 times.
Yeah, your output is radioactive or got chemotherapy in it as well, so it has toxins in it. So when you're on chemotherapy or radiation precautions, they need to take care of their output a certain way. All their bodily fluids are considered contaminated waste. So if you are on radiation or chemotherapy, depending on the doses too, it would depend. But if they are on some kind of precautions, if you pee into a toilet, you have to flush it numerous times. If you're changing the linen of a patient that has soiled the bed or things, those are considered radioactive or chemotherapy waste. They have to be disposed of a separate way because it is considered, if it's in your body, you're going to expel it as well. You want to flush those through 3 times. And so look those up. I'm going to see, I'll maybe add a slide and send it out to you of those precautions. But with those brachytherapy, with the internal radiation, they are considered radioactive for the time that those pellets are in there and radioactive. And so they're supposed to minimize contact with people and, no close contact, and also take care of their waste a certain way. So I'll get a slide together for that and send it out to you. And it's on tape, so I'll remember to do that. All right. These are just basically some extra things to point out. There are some things that are known as biologic or targeted therapy, and it just basically boosts our immune response to those tumor cells. But the biggest problems with these are the bone marrow depression. And this is something that maybe you could add to your oncologic emergency, but it's not part of chemotherapy. If they're getting biologic and targeted therapy, if they end up with if your patient develops pulmonary edema with this biologic therapy, that is an emergency of that therapy. This therapy can cause this leak syndrome and cause pulmonary edema. So capillary leak syndrome is just basically your capillaries leaking a bunch of fluid. That fluid does leak into your lungs and can cause lung problems. So if you have a patient that's getting anything, if your patient develops pulmonary edema, you're going to call. If your patient has an airway problem, you're going to call. But it is specific with this biologic or targeted therapy, this capillary leak syndrome. So you may see that. I saw it a lot on NCLEX tests, so I thought I would put it in there. I don't have a question on it. But there is this hemopoietic growth factor that just helps our normal hematologic. It boosts our white blood cells and stuff. It basically tells us to, grow more stuff to help fight. To stimulate white blood cell, red blood cell production. And then there's a stem cell transplant, which is where we take the cells from the bone marrow and put it in so that we can get more red blood cells, white blood cells. Again, I don't spend too much time on this because this is very specialized stuff that I think that if you're going to end up taking care of this, you'll know about it. I want you to know the chemotherapy and the radiation side effects. For nutrition, when you're with cancer, so I mean, when we're going through this soapy thing for, cancer, for chemotherapy, of course, our priorities are all those emergencies. Our implementations are taking care of anything that we, comfort with suspected. But one of our implementations is going to be nutrition. Cancer is, they need a lot of food because they're in a high, you're getting chemotherapy, you're killing things off, you're trying to fight off a big tumor infection. This is not the time for any diet. There are no limitations on your food. The limitation is going to be on what the patient can eat because they're not going to tolerate much. So, just keep in mind that if there are questions on what a cancer patient should eat, it should be high protein. You're going to make selections that give the biggest bang for your buck. You're not going to give a bunch of sugary stuff. There really are no limitations, but you're going to encourage stuff that will have protein. So if a milkshake sounds good to them because it will help coat their mouth and it's cool and it sounds good, would you make the milkshake with a protein milk or would you make it with regular milk? You're probably going to pick like an Ensure shake or something that is supplemental because they're going to need so much more resources. So when you are picking foods for your cancer patient, they're not going to eat very much. They're not going to have a lot of appetite. So you're going to want to get bang for your buck. So when you're picking foods, you're going to try supplemental things that have electrolytes and proteins and easily digested things. Their GI system's a mess. So probably a lot of supplemental shakes. But, just tell them, hey, there's no limitations on your food, but that doesn't mean just ice cream. If you're going to pick something and ice cream sounds good, supplement it with something, maybe freeze and Ensure and eat those or, add calories. But try to promote high protein, high electrolyte sort of stuff. Yes?
Real quick, is there a restriction on red meat after cancer treatments? Because I've heard...
I think if it would be raw, because they can't
Yeah,
have
I mean,
fruits and
it would
vegetables.
depend on what they're trying to aim at. I guess I would need to know what they were aiming at. Like after cancer treatment, is it because we're worried about them getting infected? Are we worried about them not being able to process it? Is it too hard to eat? I mean, something like red meat is hard for the body to process. You got a GI system that's not working that great. Anyway, it might be hard for them to break down the proteins in a red, in meat. So it would really depend on what the problem is. If it's the problem with altered nutrition after maybe their GI tract has been damaged by chemotherapy, maybe they can't tolerate eating hard foods to digest. Red meat's hard to digest. Takes a lot of acid and stuff. So the easier things are to eat, the more broken down. So supplements like Ensure shakes and those shakes that already have a lot of stuff broken down are easier to digest than eating a full meal of stuff. So there's that. And then, of course, there's the care piece. There's a lot to do with, how they're going to handle stress, how they're handling this. Do they have family? Do they have, do they have a good attitude? They've done studies, and again, studies are not my favorite things in the world unless they're good ones. But, there are good studies that say that, positive attitude and positive outlook is a big factor in healing. So if you can get your patients to look on the bright side, maybe kind of turn their thinking around a little bit. Sometimes most of this is just open-ended communication, therapeutic communication. Don't give advice. And I'm going to tell you for test questions and for NCLEX, for the psychosocial stuff, you never tell the patient, always, never, don't worry. If the answer says don't worry, it is not right. Do you want to hear don't worry when you are worrying? That is never the right answer. Don't worry, you can say, we're going to do what we can for you. I would like you to not worry about this. Maybe you can redirect, you can open it. But don't be like, don't worry. Don't worry. Patients are going to worry. That's okay. You would worry if you had cancer. That's okay, but redirect the worry. Okay, well, let's just say we have all of this. We're going to take care of all this. We're going to take care of all this. What things can we do to help you? What are you worried about? What can you tell me? Redirect and try to solve as many problems as you can, but don't just be like, don't worry, I got this. Try to remove don't worry from your from your coping thing. And you've probably done tons of sheets on therapeutic communication, right? So you had palliative care in block 1. So these are just a couple of slides that just review that. But if I could just point out, the hospice is not a place. Hospice is a state of mind. It's a team. Hospice is a team, and it's an approach. It's not a place. So there are hospices that are places. But being on hospice therapy doesn't mean you're going to a hospice. It just means that you're getting a lot more people on your team to help support you. And you have basically a end-stage diagnosis, so you have a lot of stuff to deal with. And so you need a team. A hospice is more of a team. So I kind of put that in there, and then, some other things to look at. So I can let you read through the slides. I do want to point out, did you talk about advanced directives and resuscitation, do not resuscitate orders and all that stuff? When your patient it's not your priority, but it is one of your interventions. If you have a patient that has a diagnosis and is not doing well or is turning the corner. You'll find this a lot in clinical. We see people coming in and you're helping them kind of really accept the fact that maybe you've been admitted 3-4 times for this, and maybe our options are limiting, and maybe you want to talk with the hospice team and discuss options with your doctor and whatnot. This is just making sure that your options are written down for everyone to read, and that the whole medical team is on the same page, and that you have had this discussion. So if you're working in a hospital, you can see that there's always does patient have advanced directives on file? Well, it's not appropriate for every patient, but if they do, you're going to want to bring that in so that we all are on the same page. They want certain things. They don't want certain things. If, God forbid, we get to that situation, we know how to handle it. It's easier to have them on file in the chart than it is to go and try and find them when there's a crisis. So we always start people looking towards that at the beginning of their hospital stay. Hey, we're not planning on using anything, but have you ever talked about advanced directive? Would you like anybody to speak with you? Those things kind of come up. Medical power of attorney is a legal document. So you have people say, don't call my husband. He's my ex. I don't talk to him anymore. We just never got it legalized. My sister is my medical power of attorney. Medical power of attorney is the person that can make the final decision when you can't make a decision. So we go to spouse. There is a hierarchy. Social worker knows it. The hospital knows it. We go to spouse first. If you don't have a spouse, we go to parents. It's spouse, and then I think to parents, and then to adult children. And there's a hierarchy. If you want anyone outside of your hierarchy making your decisions, you have to put that in writing. We don't take your word for it. The spouse can come in and say anything. Once you're married, they are your decision maker unless you remove them from that. So that's a hard conversation for people to have. And they're like, I don't want my husband deciding anything. He's a wimp and he'll keep me here forever. I want my sister to be. Well, did you put that in writing? I can't do that. So that's something that if you have these conversations, especially as a student, you're in the room a lot more than the nurses when you're talking. If your patient comes up to you with something like that, what is your responsibility as a nursing student? Report to who?
To your nurse.
To your nurse. And please just make sure that they are aware that this was said to you, because that needs to be in writing somewhere. And as soon as somebody's like, well, I don't want to, I'm like, all right, is that in writing? We need to get that in writing, or you need to commit to that, or we need to clarify that, because I'm hoping we'll never get to that. But that's something that needs to be. So that's a legal document that needs to get done. And we do have resources nearby that can talk to them about that. And resuscitation is not always just do not resuscitate. Sometimes it's partial. Oh yeah, you can put CPR on me, don't put chemicals in me. The people can do whatever they want, okay, as long as it is written down in a document that we can access. And guess what? Your family can override your advanced directives and your do not resuscitate. So have conversations with your family. Oh yes. Oh, everybody's looking at me like, what? Yes. I'm gonna. Why?
Yeah,
Because you can't make that decision anymore.
if I've already made that decision, how can they override that?
They can.
Yeah,
They can. I'm not ready. Wait. I'm not ready. Don't. I want everything done. Okay. Unless we have that full legal document, we have nothing to stand behind. We have been sued.
I have my full legal document.
You have your full legal document.
They can't keep me alive.
They can keep you alive because they can sue us if we don't.
Well, if you don't have the document, they can keep you alive, but
Yeah.
I don't see why in situations, if they have the document and it